All right, so we'll get started with high frequency ventilation part 2. We'll finish up on using an oscillator on adults and pediatrics and neonates. I don't know why I left out the neonates. And then I talk about the jet ventilator at the end. So initial settings, when you're putting a neonate on the oscillator, you're going to use 10 to 15 hertz. Children are a little bit larger, so you're going to use lower hertz. With adults, 3 to 6 hertz. And with the amplitude, remember you're changing the power to achieve amplitude. And you decide how much power or how much amplitude you need by looking at chest wiggle. So with neonates, you just want the chest to be wiggling. With larger kids, adults, not only does the chest wiggle, but you want to see the upper thigh wiggling also. And when it does wiggle, that means that you've got good ventilation of the lungs. Another way of setting amplitude is using the delta P, where you take the carbon dioxide or the PaCO2 from a blood gas, add 20 to that number, and make that your amplitude. So hertz, amplitude. Next one is mean airway pressure. If you're moving them from conventional ventilation to the oscillator, take a glance at what the mean airway pressure is on your ventilator, and then add 5 to that number, and that's what you set for mean airway pressure on the oscillator. FiO2, you start at 100%, and then you wean that down to keep sats above 88%. Let me just go back. All right, so you're putting a neonate on the vent. What settings do you use? So for a neonate, 12 hertz is some numbers that just help you to have some starting numbers. Amplitude 16, mean airway pressure 8. FiO2, you're starting at 30% and then adjusting it to get your sats. With neonates, you use a bias flow about 8 to 12 liters per minute. Having too much bias flow causes a lot of air trapping because they can't exhale against a high bias flow. And then, so I just wrote too much bias flow and they can't exhale. Okay, and then for the adult, move this somewhere. So here it doesn't give us the amplitude that we're shooting for. What is an average amplitude? No, I would be making up a number. I don't have anything written down for amplitude for the adults. So you just keep adjusting it until you get a wiggle in the chest and thigh. You got that? Can I clear it? I think when I'm typing in and recording it, it shows up on the recording, even though the chat doesn't show up, but it shows up when I type it in here. Can I clear it? There's a 3100A and a 3100B. How do you know the difference between them? Typically, it was the A was the first machine they came out with. You can use it on neonates and children. It has half of the power of the 3100B. So I would say 3100A to memorize information. Use that on neonates and pediatrics, and the 3100B, use it on larger pediatrics and adults. The 3100A has an extra knob to center the piston. Is that crazy or what? So extra knob on the front, and it's used to center the piston. So the piston is like a big motor, and it pushes forward and it pulls back. And sometimes it starts pushing forward too much and not pulling back enough. And as it's moving, there's like a little red arrow. Should we call it an arrow? Okay, like a little red arrow. And it shows you how the piston's moving. It's going back and forth. And if it's going over to the left or going over to the right, you have to use a knob to get that movement to be in the center. So you have to center the piston. We should put that on the back of our t-shirts, right? All the stuff you guys have to learn. Center the piston. Oh, here's a picture that shows it. So you see this red thing moving back and forth. It's supposed to be in the very center, showing that the piston is centered. So when it's over to the right like that, you use this knob and you turn it until it's in the center again. Okay, so some information about the circuit. Always use a heated humidifier. You can't use a heat moisture exchanger. You can't bend the circuit. Not that you have to keep it perfectly stiff. So a little bit of a curvature is okay. But if it's bent, as the oscillations are going through the circuit, when they hit a bend, it kind of like completely takes away the power of that oscillation. So you can't bend the circuit. You can put a ballard in. The ballard has an elbow, and so now you've got a 90-degree angle. So they're recommending that you wait until your blood gas is good and then put the ballard in. It says the water trap always needs to have some water in it. So little details like that. I don't know how you're going to remember this if you're setting up an oscillator. But having water in the water trap, I guess, keeps the compliance of the circuit stable. So having water in the water trap is a good thing. We talked about the bend. And then there's a bunch of valves in the circuit. There's a green one, a red one, a white one. All three of these have to do with the mean airway pressure. So the green controls the mean. The red is a dump valve in case too much pressure builds up in the circuit. So that's your pressure pop off. That's why it's red. And the white one just monitors mean airway pressure. So three different valves for keeping the mean airway pressure in the circuit. I don't know if it helps to look at this mushroom valve in two-dimensional, but when the valve, when there's air in the valve, it can touch the opening and then prevent air from leaving. So right here, when the mushroom valve is touching, it occludes the opening. So no air can get past it. And you change this by changing the settings. If you remind me when you're in the lab, I'll take one apart so you can see what a mushroom valve looks like. It's like a little tiny balloon. And when you crank up the flow going to the little balloon, it just inflates really big and it blocks off the port. So using the oscillator on the bigger kids, you're going to have a cuff on the endotube. With the adults, you have a cuff on the endotube. Well, believe it or not, if you take some air out of the cuff and you allow some air to escape around the cuff and into the mouth, it actually helps to get rid of carbon dioxide. These are weird things you guys have never heard of, right? So if you deflate the cuff, you get rid of carbon dioxide, and it helps if you have a really high CO2 on your blood gas. So with severe hypercapnia, it's causing the pH to be less than 7.2. And this is with bigger people. So 35 kilograms is somebody who's, what, 70 pounds? What is that, like an 8 to 10-year-old? No. Is it? So withdraw air from the cuff until you see the mean airway pressure drop by 5 centimeters of water, or 5 torr. No, that's a typo. It's going to be centimeters of water for pressure. Increase the bias slow to bring the mean airway pressure back to where it's supposed to be. And then it says, don't just do this, because the mean airway pressure in the alveoli is now lower, and this can compromise oxygenation. So if your O2 sats start to drop when you do this, it's not working very well. I just put this here. It's an advertisement for the oscillator. And this is how they call the oscillator on your national exam. It's electrically powered, electronically controlled piston diaphragm oscillator. They won't say the 3100A or the 3100B. That's the description that they use. So why would you recommend a patient go on an oscillator? With adults and pediatrics, there was a study that came out, it's probably going on 4 years now, saying that if patients go on an oscillator, they usually end up dying, so an oscillator shouldn't be used. And that study just cut the usage of the oscillators, and you stop seeing it. You still see it with neonates, but as far as using it with adults, pediatrics. So after that came out, then other studies came out and kind of questioned, hey, wait a minute, maybe they're dying because people typically don't use an oscillator until it's the absolute last possible thing to try to save somebody. So they're already dying. It's like, all right, let's try the oscillator, and then they die. Was it because they went on the oscillator, or was it because they were already dying and the oscillator was used too late? So they found some faults in that study, and still I don't see it coming back. So as you guys are going through pediatric ICU, maybe you'll still see it. Most likely you'll only see it in NICU. So if you were using it on an adult, it would be somebody that you have them on conventional ventilation and it's not working. Their FiO2 is greater than 60%, their PEEP is more than 10, and still you can't oxygenate. Maybe you tried Bivent, you still can't oxygenate, you would recommend the oscillator. If somebody's on conventional ventilation and their plateau pressures are greater than 30, you would recommend the oscillator. Actually, don't we have a better fix if the plateau pressure is higher than 30? We're on conventional ventilation, you do a plateau pressure and it's 30 or 32. What should you do to get that plateau pressure down? Ventilation. It's a setting. So if plateau pressures are too high, try using a smaller tidal volume. Turn down your tidal volume until your plateau pressures are less than 30.
What load are we getting? So we're in like a pressure load, you would decrease the PC over the.
You would turn down your tidal volume by turning down your delta P. Yeah.
And then volume load, you just turn up the volume.
Yes. PRVC, turn down the volume. So high mean airway pressure is another indication. High oxygenation index greater than 19, that's another indication. Air leak syndrome is an indication for using oscillation. I have a video coming up a little bit later. So this picture I took from the rep that did their talk, and it says rescue therapy with high frequency oscillatory ventilation. Don't wait too late. So, you know, the shark is coming at you. Now is not the time to decide to pull the ladder up out of the water. So the thought is we're damaging the lungs by using high pressures with conventional ventilation. And now that the damage is done, it's kind of hard to rescue the patient with an oscillator. But if you catch it early enough, like less than 24 hours with high pressures on the conventional ventilation, switch them earlier to the oscillator, then there's more success stories or lower mortality, better outcomes.
So before the shark jumps out.
Before the shark jumps out, yeah. Putting a patient on the oscillator and having those high mean airway pressures, it presses on the heart and drops the blood pressure. Sometimes they need to have fluids given or drugs to get their cardiac output up. It says auscultation of lungs and heart are not possible. When you listen with your stethoscope, you're charting the sound of the piston. Okay, here's something else that's kind of strange. So we're used to hearing air going in and out of the lungs, but when you put your stethoscope on a chest on the oscillator, you don't hear air going in and out of the lungs. You hear do, 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 do. You hear the piston. Well, if there's no pneumothorax, you don't have a right main stem intubation, you don't have a mucus plug, the do, do, do should sound the same on the left and the right. So that's what you're charting. Sound of piston is equal. And then to keep track of how well we're ventilating the patient, we can't use end tidal CO2 because we don't have a breath in, breath out. We've got what, like 600 breaths a minute. So we can use transcutaneous monitor in the pulse ox. When you're using a transcutaneous monitor with adults, You have to put it where the skin is thin, like their forearm, inside thigh. Ooh, temporal area is something I didn't mention when we were talking about it in the neonatal class. Do you know where the temporal area is? Yeah, where your temples. Yeah, that's supposedly thin also. With neonates, you can place it on their abdomen. It takes about an hour for the alveoli to open and for ventilation to improve. So they recommend waiting 1 hour before getting a blood gas. And then to open up the alveoli and improve oxygenation, they say wait about 1 up to 4 hours to get a chest x-ray. So with neonates, you know that your setting for mean airway pressure is good if you see the diaphragm at the 9th to 10th rib. So I just wrote setting for mean airway pressure is good if the diaphragm is at the 9th to 10th rib. Can we do that with the kids and the adults? And the answer is no. You're looking for the chest x-ray to be less opacified and better aeration. And that's it. So you're not looking for the diaphragm to be at a certain level with the kids and the adults, just with the neonates. And then I need to explain to you what scalloping is. I wonder if I could draw that. Do you already know? Okay. All right. So those are the ribs. You like that? You like my ribs? In between the ribs is your intercostal muscles. And of course, behind all of this are the lungs. When the lungs are over distended, it actually pushes the intercostal muscles out and they're bulging between the ribs. So if you have too much mean airway pressure, you'll actually see tissue bulging between the ribs. That's called scalloping. So what are you going to write down? Too much pressure causes bulging between the ribs? How's that? Too much pressure. How about too much mean airway pressure? Too much mean airway pressure causes bulging between the ribs. And that's what scalloping is. Did you get all of it? Hang on, guys. We're almost there. Let me clear all down. So we talked about looking at chest wiggle. If the chest wiggle goes away, it's possible that there's an obstruction in the airway or the endotube is obstructed. So let's say the endotube becomes bent and now you're not ventilating the lungs. How would you know? You would look for the wiggle to go away. What if you have a wiggle only on one side? It could be a right mainstem or a mainstem intubation, or it could be a pneumothorax. Suctioning is indicated when you see less of a wiggle, if you see your O2 sats decrease, if the mean airway pressure fluctuates. So if you have your mean airway pressure set at, what did we say for neonates, 8 centimeters of water, and then you're seeing 10, and then you're seeing 7. And why is it fluctuating like that? You would suction the airway because maybe there's secretions in the way. Do not disconnect the patient from high frequency oscillatory ventilation for the first 24 to 36 hours. Do you know why? Because you've recruited the alveoli and you're keeping them open. And as soon as you disconnect, the alveoli collapse and you got to start all over again. So you don't disconnect because you don't want the alveoli to collapse. So you have to stop the piston when you're suctioning. That's something else that's crazy, right? Stop the piston. And it's okay because you'll still have all of that extra flow from the mean airway pressure. So the patient, if they're not heavily sedated or if they're not paralyzed with a muscle paralytic, then they can breathe with the piston stopped. They just get all that flow that's going through the circuit. Troubleshooting a fluctuating mean. So this is something you have to review several times before you take your test. So you can remember what's going to cause the mean airway pressure to fluctuate. So a leak in the tubing, not enough bias flow, the patient is waking up, if there's water in the circuit, water trap's okay, but not having water in the circuit. If there are secretions in the larger airway. So all of those are going to make your mean airway pressure go up and down. Okay, and then the scenarios. And we can do the first one. So we have a neonate on the oscillator, the 3100A, set at 12 hertz, amplitude 16, mean airway pressure is 8, FiO2 is 0.4, and the I time 33%. The chest X-ray shows lung inflation at the level of the 7th rib. Does that call out to you right there? It's not at the 9th or 10th rib. The blood gas from the umbilical A line, 7.24 pH, 71 CO2, PaO2 is 40, bicarb is 19 with a -5 base. The goal is to get the CO2 in the mid to high 60s. So what is it at now? 71? So maybe like 67. So we want to get this, we want to drop the CO2 71 down to 67. So 4 millimeters mercury. So how would we do that? The settings are hertz, amplitude, FiO2, and mean airway pressure. Increase the amplitude, very good. So, and it was kind of like 1 for 1. If you want to blow off 4 millimeters mercury of CO2, you increase your amplitude about 4. Okay, good. Now, what should we do about the PaO2? It's low. We want high 40s and it's just 40. So we want to improve oxygenation. Yes, very good. If you increase MAP, that's going to distend the alveoli and improve oxygenation. Good.
Did we rise FiO2 hormone that controls FiO2, right?
You could do either one, but it would be better to do the map because it didn't show good lung distension on the x-ray. So how do you wean somebody or wean an infant from high frequency ventilation? Once the FiO2 is less than 50%, you wean the mean. And that's it. You don't wean the hertz. You don't, what are some of the other settings we don't change? The hertz, the eye time. Amplitude, you can turn that down. Once it's about 11 to 13, then they're ready to come off the oscillator. And you give them CPAP by shutting off the piston and just allowing that mean airway pressure to be in the circuit. And it's like having them on CPAP. With weaning adults and children, you get the FiO2 down to less than 50%. And if the mean airway pressure is less than 24, you switch them back to conventional ventilation. So less than 50%, mean airway pressure less than 24, switch them back to conventional ventilation. It says to keep them on the oscillator about 4 days. It typically becomes whoever the intensivist is on call. So one intensivist will come on and put the baby on the oscillator. Then after what did they do? 24-hour shifts or 12-hour shifts. So they leave and then the next intensivist comes on. They don't like the oscillator. And then they switch them back to conventional ventilation. And it just goes back and forth like that. It'll drive you guys crazy. So going through these scenarios, I'm going to kind of skip because you already know to change the CO2, it's going to be your amplitude. To change oxygenation, it's going to be your mean airway pressure and your FiO2. Always check your chest x-ray also to make sure that your mean airway pressure is set where it's supposed to be. Just want to get to jet ventilation because I said we would be done at 4 and it's getting closer. How do you control the mean airway pressure? Restrict the bias flow past the green balloon. Use an external PEEP adapter. Use an electronic pressure transducer. I probably went too quick through the lecture so that you guys aren't recognizing. So the green controls the mean is a good way to remember. Mean airway pressure has to do with the bias flow in the circuit going past the green valve. Increasing power control will most likely result in, so increase the power, what does that do to the amplitude? Yeah, so it'll give you a bigger amplitude, bigger power, bigger amplitude, bigger delta P. So will that help the minute volume? Or will it drop the minute volume? So the bigger delta P, increasing minute volume, and you get rid of CO2. The letter C. A decrease in the chest wiggle and a decrease in O2 sat. CO2 goes up. What does that signal? A, improved compliance. B, a need for suctioning. C, a decrease in the cardiac output. Letter B, very good. A need for suctioning. Because mucus can plug up an airway and now you're not ventilating the airway beyond that blockage. So that's why the chest doesn't wiggle as much. Can end tidal CO2 be monitored with high frequency ventilation? No. So we should use transcutaneous. Okay. All right. So it's going to be a little later than 4 o'clock. The banal jet ventilator. HFJV stands for high frequency jet ventilation. So when we say high frequency ventilation, we're just using a general term. And then to be more specific, are we talking about the jet vent? Are we talking about the oscillator? That's when you would say high frequency jet vent, or for the oscillator, high frequency oscillator. So the way the jet ventilator works, it delivers very short, high pressure jets of air. Exhalation is passive. The air just comes out around the jets. You have to change the adapter on the endotube. It's a triple lumen adapter that you put on the endotube. Inhalation is active, exhalation is passive. You use it in conjunction with conventional ventilation. So you have so much equipment at the bedside with the babies. You have the jet ventilator, and that's going to do some of the ventilating, but then you need your conventional ventilator also to control your PEEP, your FiO2, and to give an occasional big breath of air. So you've got like 2 ventilators at the patient's bedside. Respiratory rates 240 to 660 per minute. So this is showing the middle that's pink and the arrows are going down. So that's a burst of air that gets sent through the conducting airways to the alveoli. So in the very center, you have the inhaled air, but around this jet stream, it's possible for air to escape up the endotube and exhalation to be occurring while inhalation is occurring. It's pretty quick, isn't it? So you see, it says CO2 on the sides. So the blue arrows are showing you how the exhaled CO2 is leaving the patient's lungs. And the other thing is it helps mobilize secretions. All right, so this is a neonate's bedside. You have your jet ventilator. This is the older model. And then you have the Avia ventilator. So the Avia ventilator, it's going to give a breath once in a while. Here it's like 1 breath every minute. It's like a sigh breath. A little pressure with that. You're delivering your FiO2 and you're delivering some PEEP. So you have to have 2 ventilators set up with this. All right, so typical settings for a jet ventilator on an infant is a rate 420 per minute, peak pressure 18 to 20 centimeters of water, I time 0.02 seconds, FiO2 as needed, PEEP and backup SIMV are set on the conventional ventilator. And I went to this website and it no longer shows the interactive jet. They changed their website. Every time I go in, everything is different on their website. They're probably the best website if you are working in neonatal ICU and you want to learn more about the jet vent. They provide so much well-written information about it for you to understand. So I highly recommend their website, but yeah, the interactive jet I couldn't find. One of the settings on the jet ventilator is the servo. It's not a setting. One of the monitored parameters on a jet ventilator is the servo pressure. So let me explain it. When the jet vent has to ventilate a whole bunch of lung area, it's going to need more servo pressure. If it's ventilating a small area, it needs less servo pressure. So large lung area, high servo pressure, small lung area, small servo pressure. I'll write that down somewhere, or does it tell you? No. So let me just write that down. So I wrote servo pressure will be high when ventilating a large lung area. Servo pressure will be low when ventilating a small lung area. So it has to do with the work of the machine. I guess it has to work harder if it's going to ventilate a big space, but if it's ventilating a little space, it doesn't have to work as hard. All right, so we have a giraffe here, and we have a human here. Which one will need more servo pressure? The giraffe or the human? The giraffe. Okay, very good. All right, so keep that same concept. And now let's talk about the neonate's lungs. What do you think would happen if the jet vent, it's ventilating both lungs, and then one lung completely collapses? And now the jet vent is only ventilating one lung instead of both lungs. Will the servo pressure go up or will the servo pressure go down? Excellent, you got it. Servo pressure will go down because now it's ventilating a smaller area. So looking at that servo pressure is kind of a clue if something like that happens. If you see the servo pressure go down, it's a sign that something might be blocked and we're not ventilating as much of an area. And it lists for decreases, it says worsened compliance. So if the lungs are stiffer, servo pressure goes down. Tension pneumo, servo pressure goes down. Patient needs to be suctioned, servo pressure goes down. But if the servo pressure increases from where it was, that's actually showing an improvement for compliance or resistance. But it could mean that there's an air leak somewhere, maybe a bigger air leak, or leaking somewhere in your circuit. So increased servo pressure doesn't always mean good stuff, but it could. This is getting into nitty-gritty details. A baby that has BPD, they do well on the jet vent, but there's some changes that they realize that they have to do if they put a BPD baby on the jet vent. They'll use like a slower jet vent rate. They'll give them a higher I time. So instead of the 0.02 seconds, they'll crank up the I time to 0.034 seconds. So BPD babies increase the I time and no backup IMV rate. You want to just circle that on your PowerPoint? Just the takeaway points from this slide. A baby with BPD on the jet vent, so no backup IMV. So you don't give them a breath once a minute as a sigh. Maybe decrease the jet vent rate. And then the other thing is I time longer. Wonder if it's gonna get really loud. Oh, here it goes. He's hard to hear, isn't he?
You can see very aggressive levels of the heat that I created by removing one of the balloons from my cup. Most of the air is exhausted through the leak. Very little, if any, is getting to the alveoli. So the peripheral alveoli being off.
Can you notice that all the air is leaking? It doesn't like that. When he's using conventional ventilation, most of the air is just coming out this leak, and very little of the ventilation is going to the other alveoli, or in this case, the balloons. So keep watching.
But just molecular swimming, you can see that there's no bubbling up here. The peripheral alveoli are being indicated by the river. Even the ones adjacent to the leak are receiving some degree of ventilation by the ventilators. And there's no active bubbling through the airways that I've created in my cluster. When I run the two together, remember the conventional ventilator is at 20, the light pulse ventilator is at 30. Both ventilators are running at the same time, and you can see whenever a conventional breath comes, again, very aggressive bubbling up, most of the gas is being exhausted. The light pulse is much more gentle, much more effective in ventilating the peripheral alveoli without everything in the airway. So this is very important. Even with 10 centimeters of water more pressure, the jet ventilator is more gentle. So you will have to give a few side breaths if you're doing a temporary improvement to reverse out like this. You can see why it's so important to get rid of those conventional breaths once the lungs have been recruited and keep stabilized, inflated alveoli. The moral of the story really is raising the jet pit to the high frequency jet ventilator life pit is much safer and more effective than raising the conventional mechanical ventilator pit.
Isn't that cool to see that? All right. Was that the last slide? All right, I'm